A very good evening to one of our present here who have joined us through the live session. Today we have Dr. Daffina Blessline ma'am from the Department of OBG, Christian Medical College, Vellore. She is here to take a session about gestational diabetes mellitus. Thank you for joining us today, ma'am. The session is yours. You can start.
Very good evening to one and all present here. So thank you for the introduction. So today's topic will be diabetes mellitus in pregnancy. So diabetes mellitus in pregnancy is a very important topic. That's one topic that's going to chase behind us, starting from our theory exams to our practical exams to NEET PG. Everywhere we are going to find this topic only. Okay, so shall we start? Okay, so what are the topics that under this diabetes mellitus in pregnancy? So first thing that we will be looking into is carbohydrate metabolism in pregnancy. So what are the different adaptations that occur in carbohydrate metabolism during pregnancy? Okay. The second thing that we are going to look is what is the definition of gestational diabetes mellitus, and what is GDM, what is pre-GDM, what are the different classification systems about diabetes mellitus in pregnancy. Next, what are the different diagnostic criteria? There are actually 3 different diagnostic criteria for gestational diabetes mellitus. What are the 3 different diagnostic criteria? One is the IADPST criteria, which is the International Association of Diabetes in Pregnancy Study Group, and the other, which is also called as the American Diabetic Association criteria. Okay. So next thing that we are going to see is the ACOG recommendations. And the third thing that we are going to see is the DIPSI guidelines. The DIPSI guidelines are very important because these are our own country-made national guidelines. So it stands for Diabetes in Pregnancy Study Group in India. Okay. Next, after the diagnosis, we look into antenatal management. Next, we will look into the proper management of diabetes mellitus in pregnancy. So the antenatal parts we've seen. The other thing that we will be seeing is the intrapartum and the postpartum management of diabetes mellitus in pregnancy. And then what are the different modes of management? So management, the different time frames we will see, and we will also look into what are the different modes of management. And then finally, we look into the complications of diabetes mellitus that can occur during pregnancy. Okay, so shall we start? So first thing is the carbohydrate metabolism in pregnancy. So as we all know, pregnancy is a diabetogenic state. So why is it a diabetogenic state? That is what we are going to see. So what does diabetogenic state means? Diabetogenic state means patient is going to have increased blood glucose levels in her peripheral blood. So what is this increased blood glucose levels? What contributes to this increased blood glucose level? So if the patient is having increased blood glucose level, there are few factors that are going to contribute. So generally, if there is increased blood glucose, there's going to be increased insulin secretion. So that is what is going to happen in pregnancy also. There is an increase in the insulin secretion. But unfortunately, what happens is there is a hormone called as placental insulinase, which is going to destroy all the insulin that is going to be. So placental insulinase is going to destroy all the insulin that is going to be formed. On the other hand, there's something called as insulin resistance that occurs during pregnancy. So this insulin resistance is going to go on increasing, and it is maximum seen at around 24 to 28 weeks of pregnancy. So this has a very important clinical significance, which I will be telling you later. So one more thing is, what are the different modes that can occur? One is, pregnancy is a state of fasting hypoglycemia and a state of postprandial hyperglycemia. So why is it fasting hypoglycemia? Whatever blood glucose the mother is having, it's going to go to the fetus through the GLUT1 and the GLUT2 receptors. That's why it's called as fasting hypoglycemia. Okay. On the other hand, postprandial hyperglycemia. Why is there postprandial hyperglycemia? The increased blood glucose in the mother's blood is not responding to the insulin that is going to be formed because of this insulin resistance that is happening. So all these together will contribute to the diabetogenic state in pregnancy. There are different hormones that play an important role. Of these, the most important hormone is the human placental lactogen. This is the very important hormone that's playing an important role in this diabetogenic state of the other different hormones that play a role. The others include the placental growth factor, then the cortisol, and the corticotrophin releasing hormone. These are the other hormones, and few other transcription factors like the tumor necrosis factor alpha or interleukins like the interleukin 6 can also play a role. Okay, C-reactive protein also has a role, but the role is very minimum. So these are the different hormones that play a role. Of these, the most important one is the human placental lactogen. Okay, so now we've seen the carbohydrate metabolism. So what is gestational diabetes mellitus? What is pre-gestational diabetes mellitus? The name itself says, if a pregnant patient becomes diabetic, that is called as gestational diabetes mellitus. On the other hand, if a diabetic patient becomes pregnant, that is going to be pre-gestational diabetes mellitus. I repeat, a pregnant patient becoming diabetic is called as gestational diabetes mellitus. On the other hand, a diabetic patient becoming pregnant is called as pre-gestational diabetes mellitus. In book definition, what is gestational diabetes mellitus? It is carbohydrate intolerance of varying severity with onset or first recognition in pregnancy. So this is the book definition of gestational diabetes mellitus. Okay, so we already saw what is gestational, what is pre-gestational. Now, what are the different classification systems? The major classification is what you already know more than me, which is type 1 diabetes mellitus and type 2 diabetes mellitus. Type 1 diabetes mellitus is because of absolute insulin deficiency. On the other hand, type 2 diabetes mellitus is because of insulin resistance. On the other hand, the other classification that is used is GDM and pre-GDM, which we just saw. Okay, there's one more classification which is used more commonly and which is an exam question, which is the Priscilla-White classification. So what is Priscilla-White classification? It divides the entire diabetes mellitus in pregnancy into two classes. One is class A, the other is class non-A. Okay, class A and class non-A. So class A and class non-A, again A is divided into A1, A2. So before that, class A is nothing but your gestational diabetes mellitus. Class non-A is nothing but your pre-gestational diabetes mellitus. Okay. So the class A has A1 and A2 as we saw. So the A1 is any diabetes mellitus in pregnancy, which is gestational diabetes mellitus in pregnancy, which is well controlled on diet only. You call it as A1. GDM, well controlled on diet only. You call it as A1. Whereas GDM, which is well controlled on either OHA or insulin, you call it as A2. GDM, there are three modes of management as we all know. One is diet, one is OHA, the other is insulin. So if it's well controlled on diet only, you call it as A1. If it's well controlled on OHA or insulin, you call it as A2. On the other hand, class non-A has four different types. That is the pre-gestational diabetes mellitus, which is DFRH. These are all the types of pre-gestational diabetes mellitus that can have different manifestations. So first thing is a diabetes mellitus in pregnancy with a benign retinopathy. Pre-GDM with a benign retinopathy. So this discusses all the complications of type 2 diabetes mellitus. So any diabetes mellitus with a benign retinopathy, that will be class D. Anything with a nephropathy will be class F. And anything with a proliferative retinopathy will be class R. On the other hand, any diabetes in pregnancy with a heart disease is class H. So these are different classes of class non-A. So one more major difference GDM and pre-GDM. What is the major difference between GDM and pre-GDM? One thing is about the definition and when it develops during the course of pregnancy. The second thing is, as we all know, the blood glucose increase in case of GDM is going to begin from, in case of pre-GDM, is going to begin from day 1 of pregnancy. From the day 1 of pregnancy, she's going to have increased blood sugars. Whereas in case of GDM, it's going to begin from maximum resistance is seen around 24 to 28 weeks. So this is the point when the maximum blood sugars are also going to be increased in the blood in case of GDM. So what significance does this carry? What problem is going to cause? Is it going to cause when it is increased from day 1 or 24 to 28 weeks? What is the problem? As we all know, increased blood glucose hyperglycemia is fetotoxic. It's going to be toxic to the fetus. So how is it toxic to the fetus? It's going to induce free radical formation. Okay. So because this blood glucose increase is seen from day 1, in pregestational diabetes mellitus, free radical formation will also be seen from day 1. Whereas in GDM, it will be around 24 to 28 weeks because that is the time of maximum blood glucose increase. So this free radical formation, what is it going to lead to? It is going to lead to congenital malformations. So which is the period of organogenesis? The first 13 weeks of pregnancy. The first trimester is the period when the fetal organs are going to be formed. So that is why mellitus is more prone for congenital malformations, whereas congenital malformations are very rare or they never occur in gestational diabetes mellitus. So this is the difference between these two in that aspect. Now coming to what are the different diagnostic criteria that occur. How do you diagnose if a patient is GDM or pre-GDM? What is the cutoff that we are going to see and what are the different criteria? The first and the most important criteria is the IADPSD criteria or the ADA criteria. What is IADPSD? It is the International Association of Diabetes in Pregnancy Study Group. And what is ADA? It is the American Diabetes Association. Okay. So this IADPSD criteria, it is an international criteria. Okay. So this is a single step test. It's very important. It's a single step test. And when is this test performed? It is performed at around 24 to 28 weeks of gestation via oral glucose tolerance test. 24 to 28 weeks of gestation via oral glucose tolerance test. Okay. So second thing that they will ask you is fasting needed or not in IADPSD criteria? According to IADPSD criteria, yes, fasting is needed. If so, how many hours of fasting? 8 hours of fasting is needed. Okay. So you call the patient after 8 hours of fasting. Immediately after 8 hours of fasting, in the morning, you take one fasting blood sugar value. After taking the fasting blood sugar sample, you give the patient 75 grams of glucose. So the common thing is the quantity of water that you are going to mix. Everywhere, glucose is going to be mixed in 300 ml of water. Okay, that's standard. Some frequently asked questions with respect to this, any form of glucose tolerant or glucose challenge test is the quantity of water, which is 300 ml of water you're going to mix with 75 grams of glucose in. So after taking the fasting sample, you give this to the patient to drink, and immediately after that, you take a 1 hour blood sugar value and a 2 hour blood sugar value. Okay. So what are the different cutoffs we are going to see? So the cutoff according to the IADPSD criteria is 92, 180, 153. You will have to somehow remember these values. These are very important in clinical practice also. 92, 180 and 153. Okay. These are the different blood sugar values. Next, coming to the second criteria. What is the second criteria? It is the ACOG criteria. So if any, in case of IADPSD criteria, any one value, if it is abnormal also, you grade the patient as having GDM. Okay. So the clinical significance that I told you when I was telling about the carbohydrate metabolism is 4 to 28 weeks is the period when maximum insulin resistance is going to occur. That is why your IADPSD says that glucose tolerance test should be done at around 24 to 28 weeks of gestation. Okay. So next, coming to the ACOG recommendations. So ACOG recommendations is quite extensive. Okay. So ACOG recommends a two-step screening. That IADPSD was a single-step test, whereas ACOG is a two-step test. So what do? The first question that we ask is fasting is needed or not. In case of ACOG, for the first step, fasting is not needed. Okay, fasting is not needed, and you will straight away do a glucose challenge test. That was a glucose tolerance test. Okay, so the two steps, first step will be a screening test, and the second step will be a confirmatory test. So this first step is the screening test is the glucose challenge test. Irrespective of the previous meal of the patient, you will give the patient 50 grams of glucose to drink mixed in 300 ml of water. So after that, you are going to look at the blood sugar levels of the patient. One thing, 140. Second thing, it can be between 140 to 200. Third thing, it can be more than or equal to 200. Anytime, so this is a 1 hour blood sugar value that you will take. It's not a 2 hour, it's a 1 hour blood sugar level. After giving 50 grams of glucose, you draw a sample for a 1 hour blood sugar level. So if it's less than 140, that is normal. So will you test the patient further? No. No further testing is required because it's normal. Similarly, if it is more than 200, you call them pre-gestational diabetes mellitus. Anywhere, if you get a blood sugar level, be it 1 hour, be it 2 hour, if it is more than or equal to 200, as per the normal adult criteria, it's type 2 diabetes mellitus. Similarly, in pregnancy also, that will become pre-gestational diabetes mellitus. So more than 200, pre-gestational diabetes mellitus. So now you have diagnosed. Do you need any further testing? No further testing is required. You can directly go and start the patient on insulin. Whereas when the level is between 140 to 200, these are the patients who are suspected to have GDM. Okay, so this is the group of population for whom you are going to do the next step, which is the confirmatory test. As we already saw, the screening test was the glucose challenge test. The confirmatory test will be the glucose tolerance test. This is similar to what you did in the IADPSG. There's only one difference. Instead of giving 75 grams, here you're going to give 100 grams of glucose. So for any form of glucose tolerance test, will you need fasting or not? Yes, fasting is needed. How many hours of fasting? 8 hours of fasting is needed. So as usual, after 8 hours of fasting, you are going to take a fasting blood sugar sample. Okay. After that, you're going to give her 100 grams of glucose in 300 ml of water. Okay, once you give the 100 gram of glucose, here you're going to take 3 blood samples. It's not 2 blood samples, it's 3 blood samples. You're going to take a 1 hour blood sugar value sample, 2 hour blood sugar value sample, and a 3 hour blood sugar value sample. Okay, so IADPSD had a value of 92, 180, 153. Okay, so this 92, it's going to start here also, but not as 92, it's going to be 95. Okay, so these are some values you will have to remember. It will be 95, 180, 155, 140. Remember it as 5500. Okay, you have to remember these values also. 95, 180, 155, 140. So what is the name of this criteria? We are all fond of named criteria, which is the Carpenter-Couston criteria. This is a very important Viva question. Carpenter-Couston criteria. 95, 180, 155, 140 will be the cutoff. And when do you call the patient as having diabetes? Any 2 abnormal values, if you get, then you call it as gestational diabetes mellitus. Am I clear about the second criteria? So when do you perform the test? Usually, this is also performed around 24 to 28 weeks of gestation. But ACOG says in case of high-risk pregnancies, you have to do this test at 2 visits. Okay. First, you are going to do at the first antenatal visit. Second, you are going to do at around 24 to 28 weeks of gestation. So who are these high-risk pregnant females for whom you are going to do this 2-visit testing? So one is when they've had a previous history of GDM, previous pregnancy if they had a gestational diabetes mellitus, or if they have a family history of GDM. Okay, and if their mothers or sisters had GDM in their pregnancy, or if they had a previous baby birth weight more than or equal to 4 kg, or if it was a previous stillborn baby. If the mother has other comorbidities like hypertension, dyslipidemia, cardiovascular disease, PCOS, more than or equal to 40 years, okay, or if the HbA1c is more than or equal to 5.7 but less than 6.4 in that cases. So this will not be alone these. It will be BMI of more than or equal to 25 plus any one of the following. Okay, then you call them as high risk and then you will do this 2-visit testing. Okay, this is according to the ACOG recommendations, the high risk pregnancies. Next, coming to the very important guideline, which is the DIPSI guideline. This is the guideline that has been developed by our own country, okay, for the ease of our in PHCs and in all rural areas, we cannot be sitting and doing all these extensive tests. So for that is the reason why they've developed this DIPSI guideline. So it is our national guidelines. Okay. So this DIPSI guidelines, according to the DIPSI guideline, you do a universal screening. Are you going to leave out any pregnant female without screening saying that they are low risk? No. India is the diabetic capital. So any pregnant patient is at high risk for developing diabetes. So it's a universal screening. All pregnant patients will have to be screened for diabetes mellitus. It's a universal. So now for this, is fasting is needed? No. Fasting is not needed. So irrespective of previous meal, you are going to give them 75 grams of glucose. Okay. Once you give them 75 grams of glucose, this we've already discussed. According to the second step of ACOG, what did we see? If it is less than 140, it is normal. If it is 140 to 200, here you're not going to do a second step and all. Here you're going to directly call them as GDM. And if it is more than or equal to 200, you're going to directly call them as pre-GDM. It's a very easy test that can be performed in all rural areas. Okay. And when is this test performed? Is it performed only at one time or two times? So as per the ACOG, ACOG is the American guideline. So that is telling for high risk pregnancies, you will do two visits checking. But for our country, prevalence of diabetes mellitus is very high. So we are not going to leave any patient from the first antenatal visit. So from first antenatal visit itself, you will start checking. So this will be first antenatal visit, one check, and 24 to 28 weeks, once more time, you will repeat this test. So this is according to the DIPSI guideline. So what we universally follow in all our centers. Okay. So this is regarding the diagnostic criteria for diabetes mellitus. So next, after this, we will come to the antenatal care. So before that, actually, there's one more thing. I told you that the amount of water, the quantity of water that you are going to mix is 300 ml of water. So in addition to that, if you want to add something, you can add ice. You can also add lemon juice also to that, so that the patient will feel comfortable to drink. Okay. So what if the patient vomits after drinking the glucose water? What will happen? If it is less than 30 minutes of drinking the glucose, if she vomits, then you will call her the next day for a repeat test. If it is more than 30 minutes of drinking the glucose water, you needn't call her for a repeat test. So now coming to the antenatal care. So what are you going to do for a pregnant patient? Routine antenatal checkups are going to come to you. What are you going to do in each visit? So the most important thing is an anomaly scan. Is anomaly scan performed only in diabetic patients? No. Anomaly scan is universally performed in all pregnant females between 18 to 20 weeks of gestation. Similarly, be it gestational diabetes mellitus, be it pre-gestational, be it any normal patient, you have to do an anomaly scan at around 18 to 20 weeks. Okay. But in case of pre-gestational diabetes mellitus, we already saw that there is an increased risk of congenital malformations. So you are going to do a fetal echocardiography between 22 to 24 weeks of gestation. In addition to the anomaly scan, in pre-GDM, you are going to do a fetal echo also. Is this needed in GDM? It is not needed in GDM. Only in pre-GDM, you are going to do this fetal echo. Okay. So what about growth scans? So in many centers, growth scan is not routinely recommended. Okay, if it is like corresponding according per abdomen wise, if it's corresponding, you needn't routinely do a growth scan. But in case of diabetic patients, you will need a growth scan. Okay, two time frames are there. This is not routine or this is not some recommendation or something, but ideally once at around 28 to 30 weeks, you can do a growth scan. And at around 34 to 36 weeks, you can do a growth scan. So why are we insisting on this growth scan? Because diabetes mellitus increases the chance of two complications. One is macrosomia. Second thing is polyhydramnios. So macrosomia and polyhydramnios. So in the growth scan, what are you going to do? You're going to look at the entire fetal biometry. Okay. The BPD, head circumference, abdominal circumference, femur length. Okay. Of these, which is the most sensitive marker for detecting macrosomia? It is the abdomen. And for polyhydramnios, you will do the routine amniotic fluid estimation. Any amniotic fluid index more than 25 centimeter or a single largest pocket more than 8 centimeter, we will call them as polyhydramnios. Okay, am I very clear regarding this? Next thing is the number of antenatal visits. Any gestational diabetes mellitus, do you have to call them extra? Yes, according to the DIPSI guidelines, if the gestational diabetes mellitus is very well controlled on diet only, then in that case, you can follow the routine antenatal checkup as per the center. Okay, you needn't call them for any extra checkups. Whereas if they have gestational diabetes mellitus, okay, where the patient is on either OHA or if the patient is on insulin or if the patient is a pre-gestational diabetes mellitus on insulin, then up to second trimester, you're going to call them fortnightly. That is every once in 2 weeks. Whereas in third trimester, you're going to call them weekly with a 2-hour postprandial blood sugar value. Okay, this is regarding the number of antenatal checkups. So with the routine antenatal care, you will ensure an anomaly scan is done. And in case of pre-GDM, a fetal echocardiography is done. Growth scans are done to check for the fetal weight as well as the Liker level. And the third thing is the number of antenatal visits that you ensure. Next thing that you will look for in an antenatal checkup is diabetes and preeclampsia are very close friends. So any pregnant patient, when they are coming, every visit, you have to look at the blood pressure of the patient and check if there is proteinuria, if there's any urine albumin. Okay, so then you have to detect if the patient is having preeclampsia or not. Okay, and one more thing, diabetes also increases the chance of asymptomatic bacteriuria and UTI. Okay, so any patient, every trimester, any diabetic patient will have to have a urine routine according to the DIPSI guidelines. Everything is according to the DIPSI guidelines only that I'm telling you. So every trimester, they will need a urine routine microscopy. Okay. And one more thing that you need to ensure is diabetes is a very high risk state in pregnancy. Okay. Diabetes in pregnancy is going to increase the chances of intrauterine death. It's going to increase the chances of stillbirth. So from 32 weeks onwards, you need very strict fetal monitoring. How will you ensure the fetal monitoring that the fetus is doing good inside? Will a scan tell you? Scan will tell you, but before that, the most important thing that you will advise the mother is daily fetal movement count. Okay. According to another thing that you will do is weekly NSTs can be done, and your scan NSTs along with this AFI and biometry and all. A biophysical profile can also be done weekly. Okay. So what is this daily fetal movement count? This is a very important question that will be asked by all examiners. How do you advise the patient daily fetal movement count? You ask them to take meal. Okay, you ask them to take their regular meal, be it breakfast, lunch, or dinner. After that, they have to lie down in the left lateral position. Okay, left lateral position, and they have to count the fetal movements. Ideally, if they are having 4 to 5 movements in 1 hour, that is adequate. Anytime they are having decreased fetal movements, not only for a diabetic patient, any pregnant patient, they are supposed to immediately go to a nearby hospital. So these are the different steps of antenatal care that we've seen. Next, we'll move on to the modes of management of diabetes mellitus. Okay, so what are the different modes of management of diabetes mellitus that we are going to see? So there are 3 modes of management. So this everything is gestational diabetes mellitus. Moment it's pre-gestational diabetes mellitus, the only one and only mode of treatment. There's no role for MNT. There is no role for OHA in case of a pre-gestational diabetes mellitus. Okay. The moment it's pre-gestational diabetes mellitus, it has to be insulin. Okay. So MNT, what is MNT? It is medical nutrition therapy. So what is this medical nutrition therapy? So any gestational diabetes mellitus patient comes, you diagnose her to be GDM. Immediately you cannot tell, you go and start insulin. First step you have to do is the diet modification and moderate exercise. So what is the diet modification? That is what is called as medical nutrition therapy, MNT. Okay. So how do you do this? So the DIPSI guidelines gives a nice table that is mentioning the weight gain throughout pregnancy that is needed depending on the BMI of the patient. This will be the pre-pregnancy BMI. Yeah? It's not the pregnancy BMI. Pre-pregnancy BMI. So as you all know, it's the normal, underweight, overweight, and obese. Normal, underweight, overweight, and obese are the different criteria. So now, as you all know, it's 18.5 to 24.9. Underweight will be anything less than 18.5. Overweight will be 25 to 29.9, and obese will be 30. So what is the weight gain that is needed in each criteria? In case of normal weight, the weight gain throughout pregnancy has to be 11.5, okay, to 16 kgs. That is the normal weight gain that is needed in case of a normal weight patient. In case of underweight, it has to be 12.5 to 18 kg, 12.5 to 18 kg. In case of overweight, it has to be 7 to 11.5 kg. And in case of obese, it has to be 5 to 9 kg. This is not very important. It's mentioned in the guidelines. But what is important is, depending on this weight gain, the dietitian is going to calculate the amount of calories that is needed per day. Okay, this is depending on each individual. There is no cutoff for the calories. There is no cutoff. That depends on the pre-pregnancy weight and the BMI. Okay, so according to the weight gain, they will calculate the calories per day. So the calories are divided into 3 meals and 3 snacks. Our ultimate aim is the patient should not be eating everything in one go. So you give it as 3 meals and 3 snacks. Breakfast, you give them 11 o'clock snack, again lunch, evening snack, then dinner, and again a bedtime snack. So they are going to divide it into 3 meal and 3 snacks. And the proportion of nutrients that will be 40% should be carbohydrates, 40% should be protein, 20% will be fats. Okay, this is how you're supposed to divide your medical nutrition therapy. So now you have started the patient on medical nutrition therapy. So she came to your OPD, you diagnosed her to be gestational diabetes mellitus. You said you can start diet and then you sent her. When will you call her back? After starting MNT, you will call her back in 2 weeks with a 2-hour postprandial blood sugar level. Okay, 2-hour postprandial blood sugar level. Before I tell you that, I need to tell you the targets that are needed in case of any diabetes mellitus. Okay, what are the targets that you need to say that you have achieved your treatment? Fasting, 1 hour postprandial, 2-hour postprandial, random blood sugar, and HbA1c. The targets that are needed are fasting blood sugar has to be 95, 1 hour will be 140, 2-hour will be 120, random blood sugar will be 100, and HbA1c guidelines say it is 6, but ideally at least till 6.5 you have to maintain. Okay, beyond 6.5 you have to call them as pre-GDM. So now this will be your target. So when you start MNT, you're calling your patient with a 2-hour postprandial blood sugar level after 2 weeks. So what is the cutoff? 120. If you find that the value is less than or equal to 120, then well and good. You can tell them you can continue MNT. Okay, but make sure you keep monitoring your blood sugar levels. So how frequent are they going to monitor? So if it's up to 28 weeks, they can monitor once every 2 weekly. Beyond 28 weeks, they have to monitor every weekly. Okay, this is when it is less than 120. When it is more than 120, what do you have to do? Can you still tell them you can continue diet? No. Now it's crossed your target. Okay. So you have to do something to bring it into control. So what do? The next thing that you do is insulin. Okay. Although many centers, we start OHA only. Okay. We start metformin. And if it's not controlled on metformin, then we go up to insulin. But the DIPSI guidelines say we have to start with insulin. Insulin is the drug of choice for diabetes mellitus and pregnancy. Okay. So this insulin, you are starting the patient on insulin, then how do you call the patient? Can you again call them after 2 weeks? No. Nobody knows the ideal dose of insulin that is needed. So what do? You call her after starting, depending on the blood sugar level that I'll tell you. You will start them with a basal amount of insulin, and then you are going to call them on the 3rd day of starting insulin with a fasting and a postprandial blood sugar level. Titrate it till you achieve the target, fasting and postprandial. Okay. Once you achieve the target, then you can call them every weekly with a 2-hour postprandial blood sugar. Am I very clear? It's a very important table. You start the patient on MNT. Call them in 2 weeks with a 2-hour postprandial blood sugar level. If it is less than or equal to 120, you can continue them on MNT, but keep monitoring the 2-hour blood sugar level values. If it is more than 120, you start them on insulin. Every third day, you have to monitor the fasting and postprandial blood sugar. Ideally, they might require admission for this titration. So once you achieve the target blood sugar level, then you can call them with weekly or 2 weekly visits with the fasting and the postprandial blood sugar levels. Okay. So will you give insulin alone? No. Insulin along with MNT, along with exercise. So all three has to continue. Just because we are saying it's more than 120 doesn't mean we have to stop the medical nutrition therapy part. Okay. So this is regarding just medical nutrition therapy. Next, we'll come to insulin. So as we all know, insulin is the drug of choice for diabetes mellitus in pregnancy. Okay. So insulin, how is it given? It's given through the subcutaneous route. It is given as 40 international units per ml in a 1 ml syringe. One more question is, how many times can you use this insulin syringe? One insulin syringe can be used by the patient for a maximum of 14 times. Okay. So this is regarding the route and the next about the type of insulin. Premix insulin has to be given. So in 30:70 dilution, you give a premix insulin. Okay. And where do you store the insulin is another important question. Do you store it in the freezer? No. You store it in the door of the fridge. Okay. Door of the fridge is where you have to store the insulin. And the ideal temperature that is required for storage of insulin is a 4 to 8 degrees Celsius temperature, not in the freezer. Okay. So this is regarding insulin. And there's one more table that's mentioning the GRBS value, that is the 2-hour postprandial blood sugar level value, and the dose of insulin that you are going to give. Okay, this entirely depends on the individual, depends on what diet they are following, depending on how much exercise they are doing. But still, the guidelines are still mentioning this is a broad outline of how much insulin is to be given for what blood sugar level value. So here we take into account the 2-hour postprandial blood sugar level. Okay. The 2-hour postprandial blood sugar level and the dose of insulin. So 2-hour, what is the cutoff? It's 120. So anything more than 120. So 120 to 160, 160 to 2 more than or equal to 200. Okay. Between 120 to 160, the dosage of insulin that can be given is a 4-unit insulin of 4 units premix insulin. Okay. Then 160 to 200, it will be 6 units, and more than or equal to 200, it will be 8 units. This is only a broad outline, as I already told you. It entirely depends on each individual. Okay. So this is regarding insulin. Next, coming to OHA. Although the guidelines, as I already said, although the guidelines are saying that insulin is a drug of choice, most of the centers, we start with the OHA, okay, which is metformin. Metformin is one OHA that is accepted for use in pregnancy. The other OHA will be glyburide or glibenclamide. Okay. So the starting dose for metformin will be 500 milligram per day. You increase it by 500 milligram per week if you need. And how much maximum dosage of metformin can you give? 2500 milligram per day is the maximum dosage of insulin that is needed. Okay. In case of glyburide, you can start with 2.5 to 5 milligram once, and you can increase up to a maximum of 20 milligram once daily. Okay. And what is the most common side effect? Most common side effect with metformin is GI side effects. They might not tolerate because of the GI gastritis related side effects that it can cause. Whereas in glyburide, it has two serious side effects. One is the maternal hypoglycemia. Okay. And increased birth weight of the fetus. So because of these risks, we don't use glyburide. We generally use metformin only. Okay. So I am clear about the management part, I think. So next we'll move on. There are 3 modes of management: medical nutrition therapy, insulin, and OHA. Medical nutrition therapy, you calculate the pregnancy, you find out the pre-pregnancy weight, calculate the BMI, then according to the weight gain, dietitian will give you amount of calories per day, and she will divide it into 3 meals, 3 snacks, and give it to the patient. Okay, that should contain 40% carbohydrates, 40% proteins, and 20% fats. Okay, you start the patient on MNT, give it for 2 weeks. If it's not controlled, after 2 weeks also, you will start her on insulin or OHA, depending on the clinician. Okay, so this is regarding the modes of management. Now we'll come to the intrapartum management. So during labor, what are you going to do during labor in case of a diabetes mellitus patient? So the above 3 modes of management is only for gestational diabetes mellitus. The moment I tell you pre-gestational, there is no role for medical nutrition therapy. There is no role for OHA, although some centers give. Mainstay of treatment for pre-gestational diabetes mellitus will only be insulin. Okay. So now coming to intrapartum management, be it gestational or pre-gestational diabetes mellitus, what are you going to do during labor? Okay. So the intrapartum management, let us divide it into for these. One is the obstetric management during labor. Okay, one is the obstetric management. Second thing is the glycemic control. During labor, what are you going to do for sugar control? These are the two different things that we are going to see. So the obstetric management, what are you going to do for the obstetric management? So as usual, routine uterine contractions to be checked and cervical dilatation should be done by a per vaginal examination. Okay, timely PVs to be done to assess the cervical dilatation. Then what do? You monitor the progress of labor with the partogram. Okay. So as you all know, diabetes increases the chance of macrosomia. So what happens if there is macrosomia? There can be a tardy progress of labor that you can find out only if you mark a partogram. Okay. Next, what do? FHR monitoring. Okay. Patient will need a continuous CTG monitoring once you augment. Okay. Next thing that you will need, all these two specific things. This you will do even in a normal labor patient. So next two things that you will need is you have to watch for two things. One is arrest of descent. It's a big baby. There might be very less chances of it coming out through a normal vaginal delivery if it's a very big baby. So you have to watch for arrest of descent. Second thing that you have to watch for is at the time of labor, you have to watch for shoulder dystocia during delivery. Shoulder dystocia is by itself a huge topic. So what are the monitors? What are the different maneuvers? How do we manage? That we will see separately. So you have to watch for all these during labor. Now coming to glycemic control. Why is glycemic control very important during labor? You can manage it like normal antenatal patient. So what makes it different during during labor is patient, when she comes for delivery, either she comes in spontaneous labor or you are going to induce the labor. Okay. That time she will be taking her normal diet. But once you start augmenting the patient, okay, once you start augmenting labor with oxytocin, okay, then you will advise her not to eat anything. Okay, she can take only liquids, like either juice or water or any liquids only can be taken during that time. So that is the time when she's more prone for developing hypoglycemia. So it's very important that we make sure she's having normal blood glucose levels. Anytime she goes into hypoglycemia, baby will go into hypoglycemia, hypoxia, and all that can occur. Okay, so how do you ensure this glycemic control? So again, here our Drusilla classification will come. Okay, if it is a GDM patient who is well controlled on diet only, in that case, you will keep monitoring GRBS every 4 hourly or every 6 hourly. Okay, if you get any high value, then you can add on the insulin. Okay, otherwise during labor, that is once you start augmenting, all OHS, all insulin withheld. You don't give them anything because already they are prone for developing hypoglycemia. On the other hand, if the patient is having GDM, which is controlled on OHA or insulin, or if it's a pre-gestational diabetes mellitus on insulin, in that cases, it will be a more careful monitoring. GRBS every 1 hourly or at least every 2 hourly, you will monitor the blood sugar levels. And according to that, you will have to titrate and give the dose of insulin as infusion. Okay, you're not going to give the normal bolus doses of insulin. Here, it's going to be an infusion, okay, that you are going to give. So this 1 hourly insulin, 1 hourly GRBS will be monitored. And then according to that, the needs are titrated and insulin is given. So how will you give that? So that again, our guidelines are telling, if the GRBS values, okay, if the GRBS values are divided into 90 to 120, 120 to 160, 160 to 180. Okay, these are the different criteria it is divided into, and more than or equal to 180. This will be 140. It will be 140, 120 to 140, 140 to 180, and more than or equal to 180 will be the GRBS value. Then how much insulin that you give. So this insulin, do you give it as a direct insulin? No. This insulin has to be added in either 500 ml of NS according to the guidelines, but we usually prefer giving 5% dextrose. Okay, either NS or 5% dextrose that insulin has to be added, and the infusion rate will remain the same. It will be 100 ml per hour or 16 drops per minute. So how much is the insulin? For 90 to 120, do you need any insulin? No, it's already normal. So you can connect either a plain 5% dextrose pine or a plain NS or an RL pine can be connected. If it's between 120 to 140, you give 4 units. 140 to 180, you give 6 units. And more than or equal to 180, you give 8 units. This shouldn't be confused with the titration insulin that we give for a antenatal mother. That is 120 to 200, more than or equal to 200. You give 4, 6, and 8 units. This is 190 to 120, 120 to 140, 140 to 180, more than or equal to 180. Okay, you give 0, 4, 6, and 8 units. So this is how the dosage of insulin is titrated during labor. Next thing that comes is when to deliver. When do you deliver a GDM or a pre-GDM patient? Okay, so for that again, our Priscilla-White classification will come into role. So one class is the A1 GDM. The other class is the A2 GDM or a pre-GDM. And the other also will be A2 or a A2 GDM or a pre-GDM. Why have I written like this? Either A1 GDM or A2 GDM or pre-GDM with well-controlled sugars, A2 GDM or pre-GDM with uncontrolled sugars. Okay. So how are you going to deliver? When are you going to deliver? So the timing of delivery for any A1 GDM. A1 GDM is not a high-risk pregnancy. A1 GDM is a now, how do you treat a normal patient? That's how you're going to treat a patient with a GDM or MNT. So any normal patient with no other risk factors, do you tell them they have to deliver at 39 weeks or something like that? No. You can go up to 41 post dates also. Ideally 40 plus 2 weeks, but the guidelines are telling up to 41 weeks. Although we don't go up to 41 weeks. So anytime more than or equal to 39 weeks up to 41 weeks will be the timing of delivery for a A1 GDM. In case of A2 GDM or pre-GDM, if the sugars are all well controlled, then the ideal time will be 39 weeks. Okay, you don't go beyond that. GDM on OHA, you deliver by 39 weeks. GDM on insulin, generally we try to deliver by around 30 weeks. Okay, if everything is well controlled. The moment it becomes uncontrolled, any time beyond 37 weeks, if the patient is having uncontrolled sugars, that's an indication to deliver. 37 to 38 plus 6. With indication to deliver in the sense you needn't take her immediately. You at least admit her, try to titrate the insulin sugar levels. Once the sugars are controlled, you take her up for delivery. Okay, 37 to 38 plus 6 weeks. So this is the timing of delivery. This is also again individual based, depending on the patient, if she has any other comorbidities. If she's a GDM patient, along with that, if she's going to have other complications like IUGR and all, you cannot be waiting till post days. If she has other complications, you have to decide depending on that. This is regarding the timing of delivery. Next, mode of delivery. What mode of delivery are you going to prefer in diabetes patients? No specific mode. Vaginal delivery is going to be the safest mode of delivery in diabetic patients. Okay, more than LSCS. Okay. So when do you do LSCS? LSCS should only be done if there is any obstetric reason. Okay, if there is a fetal distress or if it's a failed induction, arrest of dilatation, any obstetric reason, you will do LSCS. One more indication that's updated is an estimated fetal weight of more than or equal to 4.5 kg on scan. That is again an indication for lower segment cesarean section. So this is regarding the intrapartum management. So we saw what do we do during intrapartum management? You do the obstetric management and the glycemic control. Obstetric management routine, cervical dilatation, partogram, CDG monitoring, watch for arrest of descent, watch for shoulder dystocia. Glycemic control, GRBS monitoring to be done. According to that, insulin infusion to be given because the patient is prone to develop hypoglycemia. Okay, then we saw the timing of delivery and the mode of delivery. So this is regarding the intrapartum management. Now let's go to the postpartum management. So post-partum management, any normal delivery patient without any other risk factors, you can ideally discharge her after 48 hours. Okay, some centers, they even discharge by 24 hours. By 48 hours, the patient should be able to go home. Okay, but in case of a GDM or pre-GDM patient, you cannot discharge them on day 2 of delivery. Okay, you discharge them on day 3 after doing a fasting and a 2-hour postprandial blood sugar level value. Doing a fasting and a 2-hour postprandial blood sugar level value, you look at the values. If it is normal, you will discharge. Okay. Generally, GDM on MNT, we tend to avoid this and we ask them to go straight away and come back with GTT at 6 weeks. But if it's GDM on OHA, you will ask them to do a 3rd day fasting postprandial blood sugar level value, and also GDM on insulin also we will do this. In case of pre-GDM, already prior to pregnancy, they would have been on some OHA. Okay, in pregnancy, we would have changed it to insulin. So that will have to continue. At least we try to start it at a half dose of the OHA that they were taking prior to pregnancy. And we see if the sugars are well controlled. You call them at 6 weeks, you do an ACPC, you see if the sugars are well controlled, and depending on that, you titrate. So on day 3, you do the fasting and 2-hour postprandial blood sugar level, and then only you discharge the patient. That is regarding the postpartum management. Then you call them at 6 weeks back with the GTT, which is a glucose tolerance test. You call them at 6 weeks. You ask them to do the glucose tolerance test and come to you, which is a 75 grams glucose tolerance test, and they come to you at 6 weeks. This is also, according to the recent update, this is also repeated at 1 year. 1 year, again, you do a GTT. From then on, every year, annually, you have to do a fasting blood sugar level value. Okay, every year, you have to check a fasting blood sugar level value. Because we already know in diabetes mellitus, 50% of the patients are going to develop type 2 diabetes mellitus. Okay, they are going to develop type 2 diabetes mellitus. So that's very important that we check these blood sugar level values. So this is regarding postpartum management. So last thing that we are going to see is the complications of diabetes mellitus that can occur. So what are the different complications that can occur? So the complications can be divided into two parts. One is maternal complications. The other is fetal complications. Okay. What are the different maternal complications? What are the different fetal complications that can occur? So the maternal complications that can occur, the most important and the most common maternal complication is, as we all know, it is polyhydramnios. Most common is polyhydramnios, increased amniotic fluid index. Okay. Second thing that can occur is a placentomegaly, which is an increase in the placental thickness. So this placentomegaly will in turn increase the chance of the patient developing preeclampsia. Okay, placentomegaly. Next thing that we already discussed is the different infections that can occur because of diabetes mellitus in pregnancy. So one is it can present as asymptomatic bacteriuria. What is asymptomatic bacteriuria? Any urine more than 1 lakh colony forming units. Patient may be symptomatic, patient may be asymptomatic. If it's a normal patient, non-pregnant patient, you needn't treat asymptomatic bacteriuria. But in pregnancy, you will have to treat the asymptomatic bacteriuria also. Okay, then they are more prone for developing UTI and they are also more prone for developing candidiasis. These are the different types of infection. That is why every trimester, urine protein microscopy is very important in diabetic patients. Next thing that can occur is preterm labor, PPROM, and abruptio placenta. Why am I telling all this? The moment there is polyhydramnios, okay, the uterus is going to be overdistended. That in turn is going to predispose to preterm labor. Next thing, because of the increased amount of liquor, the liquor can start leaking even before its term. That is PPROM, preterm previable rupture of membranes. Next is abruptio placenta. So because there is increased liquor all around, it's more prone for the placenta to abrupt and lead to stillbirth, and all those complications can occur. Okay, so this is regarding this complication. Next is when we already know that the birth weight is going to be increased in case of diabetic patients. So because there is an increase in the birth weight, there are two complications that can occur. We already delivery that is preferred is vaginal delivery. But because of macrosomia, there is an increased chance of instrumental deliveries, and as a result of that, there can be birth trauma that can occur. And the second thing, there's a huge baby sitting inside. Once the baby comes out after delivery, uterus will not contract adequately. So that is going to cause what? PPH. What form of PPH is that? Atonic PPH. Here also it can cause PPH. That will be a traumatic PPH. Okay. Last, there is one more complication that can occur, which we already saw. They are more prone for developing type 2 diabetes mellitus later in life. So these are the different maternal complications that can occur. Next, coming to the fetal complications. What are the fetal complications that can occur? The most common will be macrosomia. So what is macrosomia? Any estimated fetal weight more than or equal to 4 kg, you call it as macrosomia. I already told you the most sensitive parameter to detect that is abdominal circumference. So a very, very, very important question that is asked in all Viva, short notes, everything is your Pedersen's hypothesis. What is Pedersen's hypothesis? So there is a pregnant mother, okay, with diabetes mellitus. Sugar levels are going to be increased. This blood sugar level is going to go to the fetus also. So in the fetus, there is going to be increased blood sugar levels. So because of the increased blood sugar level, anywhere there is increased blood glucose, what is going to come? Insulin is going to come. So there is increased insulin. Okay. So because of the increased insulin, what will happen? There is increase in the production of insulin-like growth factor 1. Okay. So this in turn is going to cause the increased birth weight. Okay. So this is your Pedersen's hypothesis. Okay, is it clear? Pregnant patient, pregnant mother with increased blood sugar levels, the blood sugar will go to the fetus. So that is going to cause an increase in the insulin production. That will stimulate the production of insulin-like growth factor 1. That will lead to the macrosomia. Okay, this is the most common complication that can occur. The second complication that can occur is the congenital malformations. So this congenital malformation is very, very, very important for all your NEET exams and all your INISET also. INISET exams also. There are very important one-liners that can occur that can be asked from your congenital malformations. So the most common congenital malformation, most common system that is involved. Before that, the most common system that is involved is a cardiovascular system more than the central nervous. So two questions they will ask. What is the most common anomaly that can occur in diabetes mellitus? Most common anomaly that can occur is, I already told you, it's a cardiovascular anomaly that's going to occur. So what is that? It's ventricular septal defect. Okay. What is the most specific anomaly that can occur? Most specific anomaly is the caudal regression syndrome or the sacral agenesis. Caudal regression syndrome or the sacral agenesis. This is the most specific anomaly. One more thing that they will ask is, what is the most specific cardiac anomaly? The most common cardiac anomaly is VSD. But VSD can occur in a number of other conditions. But which is the most specific cardiac anomaly that can occur? The most specific cardiac anomaly that can occur is the transposition of great arteries, TGA. Okay, these are the different congenital malformations. Most common system that can be involved is cardiovascular system. Most common anomaly is a ventricular septal defect compared to your neural tube defect. Neural tube defects also occur, but ventricular septal defects are more common. The most specific anomaly is a caudal regression syndrome or sacral agenesis. And the most specific cardiac anomaly is the transposition of great arteries. Okay, these are very important one-liners that can be asked. Okay, so this is malformations. So in addition to the congenital malformations, there are few other problems that can occur. So diabetes mellitus can predispose to prematurity. As I already told, polyhydramnios, preterm labor. So they can be premature also. What does this prematurity lead to? Any complication of preterm labor? One is respiratory distress syndrome in the baby because of decreased surfactant production. Okay. The other is a necrotizing enterocolitis. So these are the two different problems that can occur. Apart from that, other fetal complications are abruption, stillbirth, and an intrauterine death, IUD. Okay. So abruption, stillbirth, IUD, and recurrent abortions can also occur. So recurrent pregnancy loss, an important thing that you have to evaluate is the maternal blood sugar levels. Okay. So these are the different complications that can occur in both the mother and the fetus. So next, there's one more last thing that I want to add is the neonatal complication. So what happens to the baby after birth? neonatal complication, one thing, there is an increase in the rates of neonatal mortality. Okay, there is increased mortality. Why the mortality is increased? Because as we already can be chances of respiratory distress syndrome, there can be chances of necrotizing enterocolitis. Okay, so what is the other important complication that that the baby has to be monitored very carefully? It is hypoglycemia. Hypoglycemia is any plasma glucose of the baby that goes less than 40 milligrams per deciliter. Okay, why is it hypoglycemia? So long we were discussing everything about hyper. Now why is it hypoglycemia? The same thing that we discussed in Pedersen's hypothesis. Once so far the baby was inside the mother. So when the baby was inside the mother's blood glucose levels went to the baby. Baby had increased blood sugar that was controlled by the insulin. Now the baby is out. Okay, baby is out. No longer there is the blood glucose levels from the mother. Now everything the baby is having is the baby's own breast milk that it is taking. The baby's breast milk that the baby is going to take from the mother. Okay, so that case, why is it hypoglycemia? Because still there is increased insulin production, but the incoming glucose has reduced. Okay, only thing that is happening is the increased insulin production. So because of that, what is happening? There is hypoglycemia in the baby. Okay, so this has to be carefully monitored. One more thing that can occur is, so this hypoglycemia, and during labor also baby might have undergone stress. So all that, because it's a big baby, all that can lead to hypoglycemia in turn will lead to stress, and that increases the erythropoiesis in the body. Once the erythropoiesis is increased RBC production, so there is polycythemia and there is increased breakdown also, that is hyperbilirubinemia. Okay, so polycythemia, hyperbilirubinemia, this is called as hyperviscosity syndrome. Hyperviscosity syndrome. This will predispose to a hypercoagulable state. Okay, there is hypoxia. There is increased erythropoiesis because of stress. That will cause polycythemia, increased breakdown. That will cause hyperbilirubinemia. This is called as hyperviscosity syndrome. Both of them together is called as hyperviscosity syndrome, predisposing to a hypercoagulable state. Okay. So one more thing that can occur is, these are all some metabolic abnormalities that occur in the baby because of prematurity. So there can be hypokalemia, hypocalcemia, and hypomagnesemia. All these because of prematurity. One more reversible problem that can occur is hypertrophic cardiomyopathy. So these are some of the neonatal complications occur. Okay, most important neonatal complication is the hypoglycemia. Okay, you keep monitoring the blood glucose levels when it is a infant of a diabetic mother. Okay, so this is regarding the complications. So I hope the class was very clear. So we had seen everything starting from carbohydrate metabolism. What is the definition of gestational diabetes mellitus? What are the different criteria? Okay, starting from IADPSD criteria to the ACOG criteria to the DIPSI criteria. What are the different levels? Okay, the important thing to be remembered is this IADPSG and DIPSI, it is 75 grams of glucose, whereas in ACOG, it is going to be first step 50 grams, second step 100 grams. And these values you have to remember. In case of IADPSG, it's 92, 180, 153. Any one abnormal value, that is going to be GDM. And in case of ACOG, the Carpenter-Krausen criteria for the second step will be 95, 180, 155, 140. Any two abnormal values, that will be GDM. Okay, then when to screen, what to screen, what are the different modes of antenatal care that you are going to give? Fetal echo at 22 to 24 weeks. This is a very important MCQ that they ask in NEET. Okay, all gestational diabetes mothers, they'll say pick the true statement, and they'll give you the option. Diabetes mothers should undergo anomaly scan between 18 to 20 weeks. That is a true statement. But does gestational diabetes mellitus mothers need fetal echo? No, they don't need. Pre-gestational diabetes mellitus will need fetal echo. When do they do the fetal echo? Between 22 to 24 weeks. What are the antenatal visits? Then how do you manage? What are the three modes of management? What do you do during labor? What do you do postpartum? And what are the different complications? Okay, Pedersen's hypothesis is very important. How the fetal increased birth weight in the fetus is happening, that we have to know. And also regarding the different neonatal complications that can occur. Okay, I hope the class is very clear. Thank you.
Thank you so much, ma'am. That was a very wonderful and crisp session. And we had a very high viewership rate. Almost 200 to 250 people had watched it in the live session. Thank you so much, ma'am. We are expecting many more sessions from you for our channel. Thank you
Sure.
for joining us, ma'am.
Thanks, Parthiban. Thank you.
Okay, I'll stop the live, ma'am.